developmental defects of enamel, we can find any tooth affected, one side or two sides, asymmetrically or symmetrically. And of course, we can find hypomineralized primary teeth. Look at this primary canine. Look at the vocal surface of this primary canine, associated to hypomineralized upper second primary molars. Same patient. Another kid with the hypomineralized lower second primary molar. By the way, the second primary molar is the most frequently affected primary tooth. Look at the vocal surface of this primary canine. Look at the broken enamel at the distal face of this primary canine, associated to a hypomineralized lower second primary molar. And the question is there a predictive relation between hypomineralized second primary molars and molar incisor hypomineralization? The answer is yes. Hypomineralized second primary molars can be used as predictor of molar incisor hypomineralization. Look at this second primary molar associated to a severely destroyed first permanent molar on a 7-year-old kid. That molar is still erupting and is completely destroyed. We're facing a situation that we don't even know what is causing it. Of course, we have some hypotheses, but we are not sure about the real cause. It is hard for parents to understand what is happening. Is it our fault? Say parents. Of course no, say doctor. Is it something that the kid did when he was a little boy, when he was a baby? No, say doctor. It is just a bit of bad luck. A bit of bad luck. So, this is Isabella Casian. This is my daughter. With a bit of bad luck. Look at her upper anterior teeth with a hypomineralized enamel, and look at the upper and lower first permanent molars. Right side, just the right side. And in this photo, we can clearly notice an atypical composite restoration at the tip of the vocal cusp. That composite restoration has been replaced at least 2 times during the last year. When we talk about developmental defects of enamel, it is very important to understand the difference between a hypoplasia and a hypomineralization. During the development of enamel, there are 2 big stages: the secretory stage of enamel and the maduration stage of enamel. If something wrong occurs during the secretory stage of enamel, the enamel could be hypoplasic. But if the event occurs during the maduration stage of enamel, it could be hypomineralized. So, this is a hypoplasia. It is a quantitative defect of enamel. The defect, the borders of the defect look rounded. The enamel is hard, and it is usually free of caries. This is a hypomineralization. It is a qualitative defect of enamel. The enamel looks porous and breaks easily. The left side on your screen is a hypoplasia, and the right side on your screen is a hypomineralization. It looks completely different. And that is a flower, a beautiful design. This is interesting. By the age of 9, children with MIH needed to visit a dentist 10 times more frequently than the control group. And each affected tooth needed to be restored at least 2 times. This was published in 2017. And they found that 47% of composite restorations needed to be replaced after 34 months. It is not too bad. It is about almost 3 years. Maybe it is okay for a hypomineralized molar. But 63% of glass ionomer cement restorations needed to be replaced after 18 months, which demonstrate an erratic clinical performance of glass ionomer cement restorations on a medium term. Both kinds of restoration needed to be replaced, which takes children to extensive and atypical restorations too early. Look at this crown. An atypical restoration on a teenager. Any kind of restoration has a limited life. Even stainless steel crowns can fail, especially if they were placed too early. This is an 11-year-old girl with MIH. She visited a dentist because she had a severely destroyed primary molar. She was happy. She was smiling until she knew it was a permanent molar. And due to the age of 11, her parents thought it was a primary molar. So they were waiting for the exfoliation of that tooth. That is the reason why they didn't visit a dentist. That severely destroyed, that hypomineralized lower first permanent molar was extracted. Let's talk about restorative procedures. Look at this molar. This is a hypomineralized lower first permanent molar on a teenager. And that is the pulp. The pulp is exposed. Is she laughing at us? I think she is. Problems that we face at restoring. Number 1, problems to have enough anesthesia to do the preparation. Hypomineralized enamel is not good isolating the pulp. That is why those teeth used to have heat sensitivity. Behavior problems. If there is pain, the patient will not cooperate with us. Adhesive issues. Restorations that need to be replaced frequently, again and again. Parents and patients complaining about the cost of the treatment. Expensive treatments. And I will add another point, that is aesthetic requirements or demands of the patient or the parents of the patient. As pediatric dentists, we treat children with enamel defects in primary dentition. For example, this case, hypomineralized second primary molars, both sides upper and lower. We can treat these kind of cases with stainless steel crowns, with or without pulporomies, and of course, we can treat them using pediatric zirconia crowns, pre-made zirconia crowns. Both kinds of restoration with very good clinical performance. This is after a year. After a couple of years, the first permanent molars are erupting. Look at the occlusion. After 3 years, after more than 4 years, occluding zirconia crowns against steel crowns, with no problems, with no marks or signs of excessive wear on the opposite teeth. But what about permanent dentition? What about restorative procedures for posterior permanent teeth? Look at this molar. This is a hypomineralized lower first permanent molar on a teenager. Amalgam restorations are not an option and shouldn't be used to restore hypomineralized permanent molars. So I will not talk about amalgam restorations. For many years, we have been treating enamel defects in posterior permanent teeth with composite restorations, with good clinical results if the margins of the preparation were extended into hard enamel and if the restoration was placed on the rubber dam isolation. So the key is rubber dam isolation to control humidity and extending a bit the margins of the preparation into hard enamel. Number 2, with glass ionomer cement restorations, with good but sometimes an erratic clinical performance on a medium term, with the combination of an orthodontic band filled up with glass ionomer cement. This is a good option and it should be considered as temporary restoration. Number 4, with stainless steel crowns, with pre-made stainless steel crowns, for those cases that needed full coverage. And currently, we have a new option, and I will focus the last part of this presentation on it. All of us know the advantages of using a pre-made restoration on a kid. No impression is needed, no lab work is needed, low cost. Even in partially erupted molars, we can place these restorations because we don't need to take an impression. And the restoration is placed in just one visit. When we talk about pre-made zirconia crowns for permanent molars, our main concern is always the amount of tooth reduction needed to place the crown. The question is, should we be worried about that in this case? Or maybe in this other case, should we be worried about the amount of tooth reduction needed to place a crown in this hypomineralized molar? How thick are the crowns? The thickness at the center of the occlusal surface of a zirconia crown for a permanent molar is about 0.7 millimeters, while the thickness at the tip of the cusp is less than 1 millimeter. So, the amount of occlusal reduction needed to place a pre-made zirconia crown on a permanent molar is about 1.5 millimeters. We don't need to do more than 1.5 millimeters of occlusal reduction. There is no reason to say that we do a pulpal communication during the preparation. The thickness at the cervical part of the crowns is just 0.2 millimeters. That is the thinnest part of the crown. That is a cervical adaptation of the crowns. I will call this clinical case enamel and zirconia mountains. This is a teenager, a 13-year-old girl, and this is a hypomineralized lower second permanent molar. This is her first bicuspid, and this is her upper second bicuspid. And she came to my clinic with a lot of sensitivity. She had pain with any cold, hot, or sweet food, even with the toothpaste when brushing her teeth. So, after some local anesthesia administration, I placed a rubber dam. And with a low-speed round bore, I tried to remove some of the soft dentin carefully. Of course, trying to avoid a pulpal exposure. But to be honest, that was impossible. And after at least a couple of big pulpal communications, I decided to do a pulpotomy. After controlling the pulpal bleeding, a wet cotton pellet, moist, with some sodium hypochlorite, was placed inside the pulp chamber for about a minute, maybe more than a minute. After that, the pulp chamber was rinsed with some saline solution. MTA, in this case neo-MTA, was mixed according to the manufacturer recommendations, and it was placed inside the pulp chamber. MTA was slightly condensed with a moist cotton pellet and then was covered with some resin-modified glass ionomer cement in order to protect it and, of course, in order to start the preparation to place the crown in the same visit. The rubber dam was removed and I took an X-ray. This is the preparation that I did. As you can see, no preparation was needed. I just placed the finish line 1 millimeter subgingivally. And after testing a crown, after checking the occlusion, the zirconia crown was filled up with some resin-modified glass ionomer cement, and it was cemented. The excess of cement were removed, and this is a lingual view of the crown just placed. This is an occlusal view after a week. And the tooth sensitivity had disappeared completely. Look at the occlusion, and this is important. When we are placing a crown on a second molar, if we place the crown high, even just a bit high, the anterior bite could be opened. So it is very important to check the occlusion, if it is possible, before crown cementation, and of course after crown cementation. If after crown cementation you notice that the crown is slightly high, the manufacturer is to reduce carefully the opposite tooth until the occlusion is settled. But if the crown is too high, you must remove it. Look at the tray, look at the crown, look at the gums. 3 months later, at this time, treatment that she needed. Her parents decided to wait a year. So after 13 months, they came back. And I took a lot of photos and, of course, an X-ray. So this is before and after 14 months. And the tooth sensitivity had disappeared completely. Look at the crown. Look at the gingiva around the crown. It looks healthy. That is because one of the most important advantages of the zirconia is to be biocompatible. In this photo, the lower and upper brackets were placed. In this photo, I am opening the mesiodistal space with an open coil spring to correct the crossbite of the canine. And after some months, I did it. Look at these photos. This is very interesting. I took them just after the patient entered to my operating room. No rinsing and no washing was done before taking those photos. Look at the upper second permanent molar. It looks completely dirty. Look at the crown and the gingival tissue around the crown. They look clean and healthy. This is 24 months post-op, 28 months post-op. And of course, another treatment option, a good one, I think, would be the extraction of that hypomineralized second permanent molar, waiting for the correct eruption of the third molar in 3, maybe 4 years. These patients' parents didn't accept the extraction of that molar. 40 months post-op, I am finishing the orthodontic treatment. 44 months post-op. The lower and upper brackets were removed. And look at the occlusion. And look at the X-ray. I really love this clinical case because it shows an interesting way to restore a severely destroyed, a hypomineralized second permanent molar, preserving radicular pulpal vitality. This clinical case is published in the Journal of the Mexican Academy of Pediatric Dentistry in 2019. And to my knowledge, this is the first reported case of the clinical application of a pre-made zirconia crown for a permanent molar in the world. Okay, look at this photo. This is an 8-month-old baby with a broken upper left central incisor, and the pulp is exposed. It was exposed by more than 2 weeks. That tooth was completely asymptomatic. This is important. Look at the X-ray. Look at the X-ray. Look at the apex. It's completely open. The restorative options were so limited. And of course, we cannot do a pulpectomy in this central incisor. How can we restore this tooth? Maybe an extraction would be okay. And I really wanted to save this tooth. So, after some local anesthesia administration, I placed a rubber dam. As you can see, I am holding the rubber dam with my fingers. And in about 5 minutes, I did a pulpotomy. After controlling pulpal bleeding, the pulp chamber was filled up with some MTA. MTA was slightly condensed with a moist cotton pellet. And then MTA was covered with some resin-modified glass ionomer cement. This procedure was done under local anesthesia. Her mother was holding him, was singing to him. A couple of weeks later, they came back. I did a preparation to place a crown, and after testing a trying crown, a pink trying crown, the zirconia crown was cemented with some resin-modified glass ionomer cement. This is 4 weeks later. Look at the crown, look at the gums, look at the X-ray, and this is important. In this X-ray, we can clearly notice that a dentinal bridge is being formed, which means that the pulp is alive, and that is amazing. Look at the last X-ray on the right of your screen. Look at the dentinal bridge formed. Look at the crown. Look at the gums. Advantages to keep the pulp alive. Number 1, we will get thicker radicular walls. Number 2, we will give more time for the bone for maturation. Number 3, we will get better crown root proportions. And number 4, we will allow the apex to close. This clinical case won the Anna Fuchs Award in Pediatric Dentistry in 2018, and that is a great honor for me. But what makes this case so interesting? Of course, the first reason is because the way it was treated, it was a baby, I saved that tooth, but That is not the most important reason. To understand what makes this case so interesting, I would like to share with you some pictures. This is a 13-month-old baby with an identical clinical situation. This case was treated by Dr. Camila Palma in Spain. This other case is very similar, and it was treated in Peru by Dr. Flavia La Roca. Look at the age of the patients. No history of trauma, no history of pain, no history of complications during birth, no history of hospitalization during these first 6 months. And here we can see the treatment done on each clinical case. So we think that we are facing 3 identical clinical cases from 3 different countries. And we believe these cases are a developmental defect of enamel called preeruptive intracoronal resorption, with a prevalence from 2 to 6%. All of us know cases of this entity on permanent teeth and on posterior primary teeth. But to our knowledge, there are no cases of this entity on primary incisors published. So, this could be the first reported cases of preeruptive intracoronal resorption in primary incisors in the world. And that is a great honor for me. These clinical cases are published in the Journal of the American Academy of Pediatric Dentistry. These cases were published in the Journal of the American Academy of Pediatric Dentistry on April of 2020. I would like to take this chance to invite to all of you for joining us to the Molar Incisor Hypomineralization Forum on Facebook. It is an interesting place to teach, to learn, to share clinical cases. So this is an invitation for joining us to the Molar Incisor Hypomineralization Forum on Facebook. So thank you very much. In Mexico, we say muchas gracias. Thank you.
Thank you, sir, for this amazing lecture. It was very, very good one, and I really get a lot of information new for me in this lecture. And it's a great honor to have a presenter like you, sir. It's an honor, and thank you for joining our first dental conference, Delta University, and we are very happy having you here.
If you have if you need further information about any of these topics, please send me an email. You can see my email there, and it will be my pleasure to sending you all the information that you need. If you have a question, you can feel free of sending me an email.
Okay, thank you, sir. We got your Facebook and Instagram account and YouTube channel in here, and we will share it. And thank you very much for your time.
Okay, thank you.
Thank you, sir. Bye.